Thank you, Nikhil. Thank you for that kind introduction. Thank you, Amol and Nikhil, for giving me this opportunity. I also thank Rosh for giving me the scientific platform and the information which I intend to share with you in next a few minutes or so, and that remains my conflict of interest. I will share my screen. Is the screen visible for everyone?
No, sir, unfortunately.
Sorry. Is it visible now?
Yes.
Yeah. So I think all of us are subsumed with the fact that second line treatment for a non-small cell lung carcinoma is a realistic situation that we all see in our clinical practice. So I would certainly not belabor the data because Dr. Vijay has already expounded that quite extensively, and that almost close to 50 to 60% of our patients whom we are going to see on Monday morning are actually going to be in for a second line treatment for this very difficult to treat disease few decades back. We would be probably discussing a second line option maybe a couple of years down the line when a lot of our patients actually would be receiving first line immunotherapy, and that's where the crux of the situation would lie. But currently also the challenges are plenty, and hence we are discussing this particular concept very extensively as a part of the ELCC update.
Hello.
So just to put all the colleagues, esteemed colleagues here on a common platform, that docetaxel remains the standard of care. The switch maintenance of erlotinib is being discontinued and is no more FDA approved, and hence possibly those patients who have received first line therapy with platinum based doublet would end up receiving docetaxel as a second line therapy. You also have an option of adding ramucirumab as a second line treatment options. We also have an option of vinorelbine and gemcitabine, but docetaxel has been found to be superior to all the other agents which have been there as far as the second line therapeutic armamentarium is concerned. Then 2016 and 17, we had 3 important FDA approvals, all for immunotherapy agent irrespective of the PDL status except for pembrolizumab, which needed PDL1 of more than 1% even in the second line setting to have been used as the therapeutic treatment options for second line treatment, both for squamous as well as non-squamous histology. So in essence, we have 3 options. We have Keytruda, we have nivolumab, and we have atezolizumab as one of the 3 treatment options for second line therapy of advanced non-small cell lung carcinoma, both squamous and non-squamous histology. All the 3 treatments have been FDA approved, and all of them have shown to prove an overall survival compared with docetaxel. What we need to deeply understand here is to which one do we choose from? Is there a choice of one over the other in a specific subgroup of population that we see? And do we have any specific adverse event profile to be discussed? So I will be splitting my talk into 3 important parts. First, of course, is the OAK trial, which is the phase 3 trial which actually got an approval for atezolizumab in the second line treatment of non-small cell lung carcinoma. I would then dwell on to a very small study for a real world scenario which involved a diffuse population which is typically not included in the clinical trial but very proximally and viscerally seen in our clinical practice. And lastly, I would just have a very quick snapshot of a cross trial events, obviously knowing the limitations of the so. But this is very important because we have got 3 choices at our disposal for the treatment of second line treatment of advanced non-small cell lung carcinoma. So as you all are well aware, a very important landmark study which was published in Lancet, which involved locally advanced or metastatic non-small cell lung carcinoma. It included both squamous and non-squamous histology. It included patients irrespective of PDL1 status. Interestingly, it also included treated asymptomatic CNS metastasis patient, and it had a patient pool of approximately around 1,200, but analysis of 850 was good enough considering the intent to treat population primary endpoints which were reached with the events that occurred in this group of patients. The stratification factors again were PDL1 expression histology, prior chemotherapy regimen. The randomization was 1:1, and the patient were randomized to conventional dosing of atezolizumab at 1200 milligram every 3 weekly versus docetaxel till the disease progression or a loss of clinical benefit. And the primary endpoint were overall survival in the intent to treat population, overall survival in a specific group of patients which had PD-L1 expression more than 1%, and obviously the secondary endpoint were overall response rate, progression-free survival, disease control, and safety. So let me just head on to the important Kaplan-Meier curve, which puts all these patients together in a group. And this is a telltale sign that you have got a hazard ratio of 0.73 across subgroup with a minimum follow-up of 19 months, which showed here that patients who were in atezolizumab group had a significantly more median overall survival compared with docetaxel, 13.8 months versus 9.6 months. And there is a very early separation of curve, very interestingly, because typically we see a delayed responses with immunotherapy, but here you are having fairly good response early into the event. So around 9 months, if you look at that, the curves have started conspicuously separating and being quite deep and dawningly different at around 12 to 15 months. So again, statistically significant p-value, you have hazard ratio of 0.73 in a patient across the subgroup. Now OS was further improved when TECENTRIQ was used in a patients with a very high PD-L1 expression level. As you could see in this forest plot, those patients who had a high TC3 or IC3 score, which reflects higher PD-L1 expression, they naturally and very, very logically did better than patients who did not have PD-L1 expression. Having said so, even those patients who did not have PD-L1 expression, the hazard ratio was 0.75, favoring the use of immunotherapy irrespective of the PD-L1 status as far as the atezolizumab is concerned. Again, coming back to the OAKS trial, provides us a superior 2-year overall survival benefit versus docetaxel in the intent to treat population. As you could see here, 55% versus 40% 1-year OS and 31% versus 21% 2-year OS. And as we typically see a tail of tail, that the benefits have continually lingered in the patients who have received immunotherapy, and you have seen a fairly good long-term survivors even in the second-line setting when treated with immunotherapy. These are the median duration of response, which I alluded to in the previous slide of mine. This particular bar chart again reiterates, exemplifies, and amplifies the similar concept that in an intent to treat population, you have got a deeper and a longer response, and those patients who had a good PD-L1 expression actually had an even better response when treated with atezolizumab versus docetaxel, and the difference is quite big, 6.2 versus 16 months. These are the typical X-ray CT scans that we see, and I think that is quite not nuanced to our clinician friends here, so I would skip that and would not belabor it here. Now let's look at some of the important intent to treat population and the subgroup analysis. Even in the patients which are KRAS mutant, which are typically resistant to most of the therapy, you had actually a response rates with immunotherapy. And the problem areas, of course, and that's where we are not doing good as far as the second line treatment is concerned, that those patients which were EGFR mutant and were put on to second line immunotherapy, they did not do well. And possibly that is the area wherein we have a better second line TKIs like osimertinib, or probably we need to look at augmenting the treatment more than just monotherapy with atezolizumab. So again, very, very important point to note here. And in this, probably you could see across all the second line IO trials that those patients which are EGFR mutant actually do not do well with a monotherapy in a patients with advanced non-small cell lung carcinoma who has progressed on first line TKI. Again, a very characteristic that the patients which were smokers actually do benefit, but even here the responses were seen even in non-smokers. The patients who had CNS metastasis also had a good disease control, and this is a very important clinical dogma or a conundrum that we face in our clinical practice routinely. And the patients who actually were elderly, and this is again a very common subgroup that we see today, also did benefit with a hazard ratio favoring atezolizumab versus docetaxel. So when you treat patients with cancer immunotherapy in your clinical practice, these are the typical questions that we ask. How long do we continue with the treatment, and what happens beyond disease progression? And that is where a very important clinical scenario which commonly arises, that you put the patient on an IO regimen and at the end of 4 cycles or a presumed number of cycles, you do a scan and you actually see some amount of radiological progression, but you actually seen a lot of clinical benefits. And then what do we do? So this particular trial, as I had mentioned before, actually continued to use immunotherapy provided there was a clinical benefit as per the investigator. There was no signs and symptoms indicating unequivocal disease progression. There was no decline in performance status attributed to disease progression. There was no tumor growth at clinical sites, and patients with approved alternative therapies acknowledged deferring these therapies via ICF. So this is actually a common clinical scenario that we see, that there is some disease progression or oligoprogression. Patients are actually clinically benefited and you are reluctant to change the treatment. But what do we do in this clinical practice? So this trial beautifully end up studying these aspects of the treatment as well. And if you could see here that those patients who had actually a progression on the RECIST 1.1 criteria actually did benefit by continuation of immunotherapy in terms of partial response rates of 7.1% and even a disease stabilization upwards of 40%. So which is pretty impressive in this group of patients which are actually progressing on the RECIST criteria but clinically benefiting. And hence we probably have some evidence here that we could continue to use on to IO or hold on to the important midfielder oncology drug here in the second line setting and probably continue to derive the benefit with at least disease stabilization or a partial responses. This particular Kaplan-Meier curve again reiterates the same fact that this is where actually the event of progression happened. But if you continue to use this drug beyond that, then you actually having 18 months OS in almost 37% of the patients who have actually progressed by RECIST. And if you compare that with the docetaxel arm, then the responses are quite dismal. Again highlighting then possibly this could be one of the way of going ahead in managing the patient in our clinics. Overall survival curve again stays separated post PD despite patients who have actually had progressed in terms of RECIST criteria. As you could see here that the difference between the two curves is still yawning, and the difference continues to remain separated as we go down the line and we have the mature data of this particular study. So in 2020 ISMO, there was a 4-year overall survival update. Mind you, this is POPLAR was a phase 2 study studying atezolizumab monotherapy in a patients with metastatic advanced non-small cell lung carcinoma who has progressed on first line therapy. Again, a very impressive hazard rate of 0.76 with a statistically significant p-value. And the OAK trial, which I alluded to in last few of my slides, again reiterates the same fact that the patient continue to derive benefits even in long term, and you've got a significantly impactful hazard ratio of 0.78 with a statistically significant p-value as a long-term analysis of this particular study. If you could want to belabor it further and dissect it further, then both particular population, both non-squamous, very interestingly, actually derived the benefit with atezolizumab compared with docetaxel, both in POPLAR as well as the OAK study, and even squamous cell patients ended up deriving the benefit with this particular regimen. It's no brainer that the patients who had a high PD-L1 score actually derived benefit, but the patient who did not have PD-L1 expression as well did benefited with the inclusion of atezolizumab as a monotherapy in the treatment of advanced non-small cell lung carcinoma. This particular Kaplan-Meier curves again reiterate the same fact that irrespective of the PD-L1 status, you do get benefit, but those patients who have more PD-L1 expression continue to derive better benefits with patients with atezolizumab. So POPLAR and OAK trial, this is just a summary of where we are. The median duration of the response, as is always been an attractive point for immunotherapy, is very deep and long, 26.5 months versus 6.2. And that is something which is very attractive, that the patients who continue to respond to immunotherapy do derive benefits even with the long-term and deep impact as far as the continuation of the treatment regimen is concerned. And again, the subgroup analysis has been exemplified here, that those patients who had higher PD-L1 score, those patients who continued beyond progression actually did benefit if they were actually getting clinically benefited and had consented for continuing with being on atezolizumab as a monotherapy. So again, I would not like to reiterate, this is again the similar control that possibly highlights the importance of this particular data of a 4-year long-term data of OAK study, which reiterates the important disease control measures that we have. Now, this is an important slide which I would just like to allude to, that important adverse events, that when you're talking about second line treatment, you're already concerned about toxicity. There were some grade 3, grade 4 event of any cause, but treatment related grade 3 and grade 4 adverse events were very minimal, and there was no treatment related death or interruption in a patients who were on atezolizumab monotherapy versus patients who had docetaxel. So some of the important conclusions is that a long-term follow-up of the randomized popular OAK trials with a 4-year data now suggests that consistently increased survival benefit with atezolizumab versus docetaxel in previously treated patients for advanced non-small cell lung carcinoma, irrespective of the PD-L1 expression. The majority of the docetaxel arm 4-year survivor actually ended up receiving PD-L1 monoclonal antibody immunotherapy as a subsequent anti-cancer treatment. Radiographic response is not a requirement for a long-term survival, as some of the patients continue to derive benefits even they have technically progressed by the RECIST criteria, and atezolizumab showed a consistent and manageable safety profile with no grade 4 and grade 5 adverse event. I would just go on to give you a glimpse of what this TAIL study was. This was basically a global single-arm study of atezolizumab monotherapy in diverse population. And just to highlight what are those diverse population, those patients who had performance status 2, those patients had a severe renal impairment, those patients have some amount of autoimmune disease, those patients who have active or chronic hepatitis B and C viral infections, those patients who had untreated asymptomatic CNS metastasis, actually a typical real world scenario patients that we see, though obviously it's not a phase 3 clinical trial, but they did continue to derive benefits, especially the patients who had a poor performance status, especially those patients who had got a severe renal failure, and even those patients who had a mild to moderate autoimmune dysfunctions continue to derive benefit. And of course, large number of patients also had OAK-like population, typical clinical trial population that we see, and they actually continue to derive benefit with the inclusion of atezolizumab. Again, reiterating the fact that important real-world evidence that a diverse group of patients could actually get benefited with inclusion of atezolizumab as a monotherapy. Again, summary of primary analysis, it's confirmed that safety profile of atezolizumab monotherapy is diverse in a previously treated non-small cell lung carcinoma population. Just to conclude my talk, as I had mentioned before, that cross-trial comparisons are hazardous, but here we have CheckMate 017, nivolumab versus docetaxel, CheckMate 057, nivolumab with docetaxel in non-squamous, Keynote 010 pembrolizumab in squamous and non-squamous only with PD-L1 expression of more than 1%. And then we have the OAK study with squamous and non-squamous irrespective of PD-L1 expression. Though obviously cross-trial comparisons are hazardous, this is the data that we have. All of them actually showing improved response rates, improved overall survival, and we are actually spoiled by the choices. But if you could just sort of tease some of the important characteristic here is that probably you have got a little better data of atezolizumab in a patients which are non-squamous population. You slightly have improved data in a patient who has got a PD-L1 expression even at a lower level, and if you could see here is that this particular chart, that squamous and non-squamous 12.6 versus 8.9 months in a patients who have actually no PD-L1 expression continue to derive benefits with patients when treated with monotherapy. So I think we have multiple choices here now in our therapeutic armamentarium. These are the NCCN guidelines, as we have mentioned here, that nivolumab, pembrolizumab, and atezolizumab, all three have been approved for the treatment of metastatic non-squamous as well as squamous non-small cell lung carcinoma who has progressed on first-line therapy, and they continue to derive overall survival benefit with this particular group of therapies that we have. I thank you all for this patient hearing and would be happy to take any questions if any. Thank you so much.